Good morning. National Institute for the Empowerment of Persons with Multiple Disabilities, located at Chennai, is very happy to present this program. Good morning, sir. Good morning, sir. Shall I start? Mm.
Yes, Anushya ma'am.
Yes, sir.
Shall we start?
Yes, sir. Yes, sir. I'm waiting for your permission, sir.
Fine, please. We will start up.
Yes, sir. Thank you so much, sir. A very good morning to everyone. I am Anusuya, Rehabilitation Officer from Department of Special Education, NIEPMD, Chennai. I welcome you to the international webinar organized by Department of Special Education, NIEPMD, Chennai. This international webinar happened in the encouragement, guidance, and support from Sri Nachiketa Raut, Officiating Director, and Sri P. Kamraj, HOD, Department of Special Education, NIPMED. I'm thankful to your support and giving me this privilege to organize. There has been lots of dedication, communication, and professional drive to disseminate knowledge and expertise through this international webinar. And I'm very happy to share that more than 700 participants from United Kingdom, Bangladesh, Malaysia, Oman, Canada, and from all over India have joined for this webinar. I thank the participants for their overwhelming response. Now we'll move on to the inaugural of this program. Let's start with the thankfulness and gratitude, heartfulness to the Almighty God. And I now welcome our director, Shri Nachiketa Raut, to present the inaugural address. For his credits, he has got lots of publications, more than 14 international publications, and 9 and 6 books he have written. And he has authored and guided many dissertation and PhD program. Hearing aid, which received the Shashrut Award given by Department. He is the scheme, the DIP scheme to introduce the year hearing aids into the government of India in 2013. He has more than at various national conferences and international conferences. He had been posted as officiating director 15, and again he is back to us as an officiating director. I'm so happy, sir, to welcome you to deliver the inaugural address. Over to you, sir.
Poonam, and it's a fantastic effort, perfect in a body which doesn't execute out the commands as it. What does it mean? To hold this particular pamphlet, I command my hands to pick them up. I command my fingers or the prehension skills to hold them up. I command the rest of the bones in my neck to fit, take the input, process it, and I'm speaking out, in which the commands from my speech centers are going into the speech organs, which are working in coordination so that this particular speech comes out. A person with cerebral palsy, it happens out here well, but it may not be executed out with the body. So the first thing is giving accessibility, making information accessible in terms of understanding it and in terms of expressing it also. So alternate communication is something which we require out for people with cerebral palsy, because the body is not okay. So we require out specific furniture modifications. So communication, AAC, a speech therapist inputs are required out. For furnitures, for feeding tools, we require an occupational therapist. For education purpose, we require the inputs of the special educator. For gross motor, fine motor things, we require the inputs of a physiotherapist. And for the psychological well-being and to address out multiple issues regarding psychological well-being, we need a clinical psychologist also. There would be other issues, synthesize it and implement it. So many things need to be there if the person is going to a multidisciplinary setup. So the other setup to which the person may go is the interdisciplinary setup. The interdisciplinary setup doesn't go much different, but the core thing which happens is the person, when he goes to each of them separately, the physiotherapist, occupational therapist, speech therapist, special educator, clinical psychologist, dietitian, medical doctor, etc., all of them sit down together at least once, decide out upon the therapy plan which they would be following out, and the goals each of them would be targeting. At least the goals which are done are known by each of them. But here also, the person with cerebral palsy and the escort needs to go down to different professionals separately and take up their advices. So the interdisciplinary model again is demanding in terms of, you should be fortunate to get all of them. Finance, time, the amount of effort required out for the person to go to each of them. So there is a third model which was prescribed out, known as the transdisciplinary model, in which they said that all 6 of them empower each other. There is a very systematic and skills which and emotional demands on the person with cerebral palsy. It reduces the emotional therapists and special educators. So many demands are reduced out. But are we ready with such a approach? Systematically, we have not yet developed. It's very important that we start the more holistic way to look at things can be put to use. And fortunately, that's one of the Institute for Empowerment of Persons with Multiple Disabilities. So it's a very welcome move.
Abnormal forms of labor in which the child has been partially suffocated induce the nervous system and results in spastic rigidity and sometimes paralytic contraction. It was here he first defined what is now known as spastic cerebral palsy. So, leading to that, we had Dr. Sigmund Freud, neurologist, apart from his major profession. He was the first to state that cerebral palsy might be caused by oxygen deprivation at birth has been initial understanding, but the further studies in this area has moved on to an understanding that it can be caused even during the pregnancy period, that is gestation period. So the abnormal development before birth may also contribute for a condition of cerebral palsy. So with this an understanding, with their pioneer contribution in the area of cerebral palsy, let us understand now what we have got to learn about palsy is group of neurological disorders that appear in infancy or early childhood and permanently affect body movement and muscle coordination. Here, the cerebral palsy affects a motor area of the brain's outer layer called the cerebral cortex, the part of the brain that directs muscle movement and also affects the ability to maintain posture and balance. To get a crux of this definition, it really puts forward it is a disorder which has got its deficit in body movement and muscle coordination. The area that has been affected is the cerebral cortex. We understand the cerebral cortex has its own role to play in directing the muscle movement and also to maintain posture and balance. So the lesion or the damage in those particular area of brain has got its own resultant in individuals with cerebral palsy having deficits in their body movement and muscle coordination. And this condition has been accepted into a legislation level in the year 1999 by the National Trust Act, which states cerebral palsy means a group of non-progressive condition of a person characterized by abnormal motor control posture resulting from brain insult or injuries occurring in the prenatal, perinatal or infant period of development. So again here we are getting to know that it is a non-progressive condition. Train infections, complications occurred in the antenatal period when the child is in the process of developing. So if it is a low birth weight or it's a prematurity, we all know it can. So having understanding the antenatal causes, the perinatal cause that we may have to know as a key indicator is the birth asphyxia, the complicated labor and delivery. Here what we have to understand is the supply of oxygen through the blood to the fetus. This needs to be uninterrupted. So if there is a delay in supply of oxygen through the blood, there is a there is a chance or at risk of having a child born with a condition of cerebral palsy. And moving on to the postnatal period, the causes can be contributed by the non-accidental injury, head trauma, meningitis, encephalitis, or cardiopulmonary arrest. So these are all can be a condition that can happen immediately after the birth of the baby. So it can be like meningitis and encephalitis, as we all are aware, it's an infection caused to the layers of the brain, which can in turn cause a lesion or damage to the brain. What we have to understand is damage to the cerebral cortex, area that is more specific to motor informations, where the reflex arc is being created by the information from the brain to perform as an outcome as a gross motor activities is all going to be in interruptions. Like that, there's going to be a disturbance in performance of this total arc. The information from the brain and the performance through the behaviors. So meningitis and the encephalitis can be a contribution as a risk factor in becoming a condition of cerebral palsy. So having known about the risk factors during antenatal, perinatal and postnatal period, where we understood that antenatal period has got 70 to 80% of contribution and a 10% a major contribution even during the birth asphyxia condition. So like combination of these two can lead to a child or an individual, a child born with cerebral palsy condition. So we'll move on to types of cerebral palsy. When we talk about types of cerebral palsy, it can be categorized under three major subtypes. Like it can be under neurological deficits based on extent and area of damage to the brain and type of movements involved and areas of affected limbs. We'll move on to that one by one. So neurological deficit which we here mention is about extent and area of damage to the brain. So this can be at pyramidal tract or extra pyramidal or it can be mixed. We talk about pyramidal, it is originates from motor areas of the cerebral cortex, and if it is extra pyramidal, it is basal ganglia and cerebellum. So mixed can be combination of pyramidal and extra pyramidal. The types that is based on the damage to the brain, we'll have an understanding through this slide. When the damage is in the cerebral cortex area, stiff muscles, that is spasticity associated with damage to or developmental differences is seen. When it is basal ganglia and cerebellum, we all know this all will contribute to the extrapyramidal. And there, an uncontrollable movements, which is dyskinesia, will be the outcome of damage to that area. When it is cerebellum being the area of damage, poor balance and coordination, which we term it as ataxia. The coordination, the postures will have its own association. So this is an area of affected limbs are being suggestive of the types of cerebral palsy. We call it as monoplegia, hemiplegia, diplegia and quadriplegia. When we call it as a monoplegia, it affects one limb, usually one arm. When we call it plegia, it affects one side of the body, that is maybe can be a left side or can be a right side. When we call it as a diplegia, it affects either both the arms or both the legs. So it can be of that combination. And when we call it as quadriplegia, it affects all four limbs of the body. There's spastic monoplegia, spastic hemiplegia, spastic diplegia, and spastic quadriplegia. These all are grouped based on the area of affected limbs. Okay, spastic cerebral palsy, what really we would be seeing from individuals having cerebral palsy. It's an increased muscle tone, tense and contracted muscles. They'll have a stiff and jerky and awkward movements. There's an increased deep tendon reflexes. It's most common in 70 to 80% of individuals with cerebral palsy. This is the conditions that these are the symptoms. So these are the things that we tend to see if you have diagnosed a child as spastic cerebral palsy. When you call it as a dyskinetic, that is, this is non-spastic and the area of damage is to the extrapyramidal tract. Here we call athetoid. It's involuntary, irregular jerking movements. This is how it is observed. It's involuntary, irregular and jerking movements characterized by it can also happen with a slow writhing movements that usually involve the extremities of trunk, neck, facial muscle and tongue. Slow twist the trunk or extremities with an abnormal posture is seen. The involvement of pharyngeal and oral muscle causing drooling and dysarthria, that is where the imperfect speech articulation is seen for a child with dyskinetic condition. So having understood this, where it's athetoid, dystonic move on to this category. We'll understand about ataxia. This is again a non-spastic extrapyramidal area of damage. Here if you see individuals having this condition usually will have a wide-based gait, rapid and repetitive movements perform poorly, disintegration of movements of the upper extremities when the child reaches for objects. When you see the image there, you see a person having ataxia condition is walking with a wide base, but when they walk with a wide base, you see there is a bend of the knee there, which really supports them in balancing. So when they walk, they will have a bend with their knees with a wide base gait and they'll process. So this is about ataxia. And what are the other associated problems that we can come across when there is an individual having cerebral palsy? There is hearing and visual problem can occur. Like we tend to understand that children with cerebral palsy do have strabismus, nystagmus, where their muscle coordination really disturbs, and there is a probability of children with cerebral palsy having their vision functionally not to the normal expectation. There can be a low vision, or that can be corrected with the refractive errors can be corrected with the spectacles, or ophthalmic consultation is more wanted there. And then we know sensory integration problems can come up, feeding problem, behavioral emotional difficulties, communication disorders, bladder and bowel control problems, even digestive problems, because it's more of less of movement has been seen, less of physical activities are observed. So probability of digestive problems are there, and skeletal deformities, dental problems, intellectual disability and learning disability in some cases. The seizures and epilepsy may also be there. So having understanding with an associated problems, we'll see what are the challenges they'll come across. So challenges that we see, mentation and thought process are not always affected, but they are trapped in their bodies with their disabilities. So the ability to express their intelligence may be limited because of their difficulties in communicating. So these are the challenges that really limit in expressing their potentials that is trapped within their bodies. Yes. What are the implications? Like like a person having a cerebral palsy, what are the implications that could lead to? In a day-to-day life, or in his education aspects, or in a workplace? What are the implications that it can lead to? Difficulty in performing life skills with limitations in their motor skills. So life skills performance is going to be difficult in areas where there is more of motor domain is involved. Mobility restriction in exploring their physical environment and learning from it can be a challenging. Speech may be impaired, may have difficulty using conventional chairs and tables in a class or in a workplace. Difficulty in finishing assignments or tests or the job assigned in the work area in a prescribed time limit. Experiences fatigueness when speaking to a person for a long time, wherein the coordination of muscles, posture, body language, so much is involved in communication. So obviously, when there is an individual having a cerebral palsy, have to speak for a long time, he or she may have fatigueness with their experiences in speaking for a long time. Requires additional time, support of compatible assistive technology, and exemptions for coping with their curricular demands, or maybe in some of their tasks demanded in their workplace. Individual may need specialized furniture and also transport means. Accessibility component needs to be taken into consideration when there is transport to be organized, transport to be accessed, or the furniture to be utilized for the performance of the individual with cerebral palsy. Difficulty in using regular writing tools. The writing tools could be a pen, pencil, marker, whatever it may be. So difficulty in using such regular writing tools, there will be a difficulty in holding a pen, holding the tool continuously for a long time. So the grasp aspects, the grip of it, the coordination in executing the writing task, all that needs to be going to be a challenge for the individual. This is all an implication because of the condition of cerebral palsy. Activities involving use of hands like turning pages, writing, taking out books from a bag, or taking out even a laptop from a bag when they have to perform, or taking out anything from any container can be difficult, hence have to be adapted suitably for them to have a smooth conduction of whatever activity they are going to perform. Challenges with input, output, and information processing when working on assignments and assigned task in the job, or any examination or any interview they need to take up, there all it's going to be a challenge. What we are going to do with, or what we are going to do further or support such individuals with cerebral palsy having all these implications just because of the condition. Yes, as we rightly heard from our director, he said there need to be a holistic management of individuals with cerebral palsy, wherein a transdisciplinary approach will be a suitable means of intervention. For having that understanding, what I would leave this session is, like, we'll be having further few speakers who are nationally and internationally placed and who are expertised in the area of physiotherapy, occupational therapy, or speech language communication. Will be adding on an educational specialist. Will be adding on to how we can provide a holistic management if an individual with cerebral palsy is being approached. This can be even at home, at workplace, or at education center, or wherever it can be, even in public or society. This is going to be a webinar where we are going to have an understanding of all these components to have a holistic approach towards management of individuals with cerebral palsy. I end my session with this. Thank you all for your kind attention and patience in listening to me. Yes. Listening to the first session on overview of cerebral palsy. Now I'll be moving on to the next session. I'm really happy to call upon Shri. I'm happy to introduce my HOD, department HOD, Shri P. Kamaraj, uh, to his credits. He has he has been having more than 20 years of experience in the field of intellectual disability, and he has specialization in the area of cerebral palsy, multiple disabilities, autism, and other disabilities of his specialty. And sir has got lots of publications in national and international journals. Sir has been a resource person for many conferences. I'm happy to introduce, I request the participants to have full attention in listening to his presentation, which is going to help us in understanding the educational component in the holistic management of individuals with cerebral palsy.
Good morning to all. Thank you very much for organizing such a wonderful webinar at the international level. Am I audible to all?
Yes, sir, you are audible, sir. Yes, sir.
Thank you.
Yes, sir.
So this management of children with cerebral palsy is a very Herculean task. It's a very challenging task. So we may be planning one thing, and then the children's demand may be something else. As a result, we undergo a lot of confusion in planning and then providing the services for children with cerebral palsy. So we need a lot of professional support for providing the interventions. For providing educational intervention, I'm going to share some of the ideas, experiences, and the challenges which we come across while working with such group. I'll be also sharing some of the ideas how to overcome such issues at home. Internationally, next. Internationally, around 2 to 3 out of 1,000 children born with the condition of cerebral palsy. So it was reported internationally. More than 60% of the children with cerebral palsy are affected with spasticity. Our Indian government reported somewhere around 2.68% of population as person with the disabilities, out of which the multiple disabilities are having more or identified more. The motor issues are identified 7.1% among the person with the disabilities identified. So this shows that the multiple disabilities, the number of people identified in the area of multiple disabilities, the children with motor problem also might have interpreted and then identified as multiple disabilities. Next. The problem observed in among the children with cerebral palsy is the posture and movement. The problem of posture and movement. So that is happened due to insult to the tender brain, and it is irreversible in nature. So that makes an adverse effect on performing the motor activities, performing ADLs, and processing the sensory, processing the information through that sensory pathways, and finally issues. Because no one is, people are not similar, so they are unique. The same condition of children with cerebral palsy, the needs may be different. The spastic condition of various people, the needs may be different. The ataxic condition of the various people, the needs may be different. Similarly, the severity that also decides. The less severity that gets space in the mainstream easily, then the more severity people, the severity that makes significant role for mainstreaming or providing educational support. Next. So let us understand the challenges observed in motor performance. So we can easily observe the difficulties in maintaining the symmetrical features of children with cerebral palsy while lying, sitting, standing, and moving. The difficulties also may be observed on the body movements for doing various activities. The children may be exaggerated are inhibited or showing no movements of the body and limbs, that leads to imperfection in doing the activities. The improper planning of movements, that leads to injury or fractures. So it is unfortunate the children with cerebral palsy may have the issue of getting injuries and fractures often. And with that, the associated conditions like epilepsy, inattentiveness, and other sensory issues. So those are all hindering the learning of certain activities. Next, so we can also observe the sensory activities, the challenges which we come across in the sensory activities. Next, madam, that is over. Next. So the senses are gateway. We can understand that senses are gateway of learning. So that is disturbed among the children with cerebral palsy. So we can observe children with cerebral palsy having various issues in the visual perceptions or the field of issues, field of visions. We can also observe poor auditory performance. So discrimination will be very challenging for them. And we can also observe the response to stimuli and making an effective planning and move around. So that's a very big challenge for them. They also show this. Some of the children will have the poor reaction to certain odors and taste. So these are all some of the challenges we can observe in the sensory aspects. Next. So I would like to request the audience to respond at least one or two the challenges or difficulties which the children with cerebral palsy come across in ADLs. So what are all the can you close this slide or go to the previous slide? I request the audience or the participants to identify some of the challenges exhibited by children with cerebral palsy in performing ADLs. What are all the challenges we observe among the children with I request the participant to respond. What are all the challenges we observe among the children with cerebral palsy in performing the radial activity of daily living? They can use the chart box. So we can observe the unusual position while performing ADLs, while feeding, or doing other that activity of daily living. So we can observe the unusual position, and they find it very difficult in planning and reaching, grasping, and manipulating the object
Excuse me, sir.
or using the ADLs.
Excuse, sir.
Yes.
Sir, the participants have put in chat box. They have said it can be feeding, eating, grooming, movement difficulties, tying of shoelace, dressing upper and lower body, need assistance in toilet behaviors, holding objects. Yeah, this is folding clothes, chewing, biting. These are the using restrooms. So many responses are there for your question, sir, from the participant side.
Yeah, that's they are all right. They are all coming close to all our observations.
Yes, sir. Yes, sir. Yes, sir.
So we can also observe the exaggerated or inhibited or no movements of the body and limbs that leads to failure or imperfection in doing the ADL. So what they will do, they will be exaggerated. Sometimes they fail to drop. They tend to drop the objects, and then some of the children they were unable to reach, or some of the children they fail to move. They fail to make an effort to move. So these are all the challenges we come across in performing the ADL by the children with cell palsy. Some of the challenges like that drooling, difficulties in sucking, swallowing, chewing. So these are all very well observed among the children with cell palsy in the while performing the eating skill. So because the eating skill is mainly performance of the motor activity, so as a result, a feeble movement is observed in the sucking and swallowing activities. And because of feeble movement, the overall feeble movement, so we can observe drooling among the children with cerebral palsy. So this, because of this, they tend to take that poor intake. So they fail to take that intake properly, and then they look very malnourished, and then that leads to other health complications like constipations, and they make certain accidents on bowel and bladder movements. So that is because of due to poor movements and communication on time. Next. So the challenges are also observed in performance of communication, that is poor or lethargic use of the oral and augmentation. So we will be using our body for communication along with the oral communication, so that body movement is not effectively used. So they fail to use or not effectively using the body movement. Even the oral communication also affected. So they keep silent, or they participate partially or incomplete participation in the process of communications. So often we can observe the children with cerebral palsy, they get tired, and sometimes they quiet and then withdraw in the process of communications. Next, we can also observe some of the challenges in performance of academic programs. So this academic program, the participation in the academic program decided based on the cognitive intact, the cognitive impairment. Children with cognitive intact, they try with various modes. They try with various ways and means to participate in the academic programs or curricular programs or that educational programs. But whereas the children with cognitive impairment, associated with cognitive impairment, they find very difficult to participate in the academic programs. So this cognitive impairment versus cognitive impact that plays a major role for providing education to children with cerebral palsy. So this academic program that goes to pre-academic program and then academic program. So in the pre-academic program, it is observed that the children tend to show the object with improper location. The object will be in one place. The direction will be some other places. Some of the children with that visual issues, so they look at the object in different directions. When it comes to academic program, we can also observe the children tend to show the letters, numbers, and then directions with improper locations and time. So they take more time to locate. They take more time to identify. So mainly the motor output is affected. So the input they receive one or other ways, but the motor output is mainly affected using the oral and then any other mode of communications. The educational program for children with cerebral palsy is very well placed, very well suggested by DINOs. So maybe in the inclusive education program or integrated program or home-based program. So these people may be benefiting in any of the programs. So inclusion, certain people they may be benefiting from inclusive education program. To some extent, some of the people they'll be integrated and then benefiting. Some of the people they'll be benefiting from home-based program or home program. But when it comes to education, so there are options. The general education program that has two programs. That is regular education classroom program. Another one is that flexible program of open education program that is available. Next, madam. The open education program, so that is available and that is supported with special education program. We cannot ignore a special education program or supporting or getting through the general education program of regular or open stream. So the special education program plays a major role for education of children with cerebral palsy. So we will be providing certain support so that they'll be accessing the education or will be adapting and providing the content to children with cerebral palsy for benefiting or accessing the education. So the support required for children with cerebral palsy in the educational setup. Next, madam. So n number of supports are required for education of children with cerebral palsy in the education setup. Like the parents, they are the first teacher and their support is very much essential. And the subject teacher, so their support, understanding of children with cerebral palsy and the needs of children, understanding the needs of children with cerebral palsy, and the differentiated instruction or cross-categorical instruction that address to the needs of children with cerebral palsy. So the subject teacher is very much important, very well important in this program, and the special educator to support special educators to support the general education environment. So that is very much essential, and we also need to keep the health workers and the additional program providers, providers, health and nutrition. So those people are also need to be included, and we need to keep up the therapist in the system. The administrator needs to be oriented. The policymakers, they also need to be oriented on the issues and the needs required for education of children with cerebral palsy. The support, next madam, support required inside the campus. So that is the welcome attitude. The welcome attitude in the climate, in the learning environment. So that is very much essential. And then accessible classroom, the seating arrangements that needs to be provided to access the education of children with cerebral barrier for environment to access the classroom, access the campus, reasonable accommodation to benefit the academic activities, the peer learner support, the peer group support. So that is also needed. And then the technology, the enabling technology which facilitate the children to access the educational content. So we also need to keep a space for the mobility resources and the communication resources for supporting the children with special, the children with cerebral palsy in the mainstream program. There are certain activity which the parents can plan at home to overcome the motor issues. So I have to remember, next madam, I have to remember our the consultant, UNDP consultant, like the Werner, David Werner, he was instrumental for creating certain facilities in the home and then community using the available resources at home and at community. The parents have to remember the do's and don't do's, and they should have the contact number of all the therapists and other service providers for planning and doing the motor activities. So they need to mobilize the local resources, no cost or low cost material for the purpose of doing the motor activities. And they can pair up with other children, non-disabled children, in the process of play and other activities to benefit the motor activities. They can use the walker. They can use the walker, local trolleys, wooden frames, and other furnitures available in the home and community to facilitate the motor activities. So it is experience that using the car tire, so the balance is achieved, the stability is achieved. So they can use the scooter or car tire for achieving certain activities. And they can use head guard, knee and elbow guard for protection from injury and fractures. The parents can think of low cost material. The parents can think of low cost material such as using their own clothes, like cotton sarees, dhotis, and other material, locally available material, which is available at home or in the community for protection and facilitating certain motor movements. parents all need to be remember keeping the appropriate position for doing all the activities. Some of the materials, some of the activities which is available locally, and they have to make best use of all this material so that the motor activities are facilitated with the locally available material on par with other children. Some of the materials are suggested by, planned and suggested by David Werner. So that is, he created a concept that is a disabled village, and he used all the local material to facilitate all the activities for the children with disabilities, including children with motor movement or the children with the cerebral palsy. Some of the activities to overcome challenges of ADL at home, the parents need to keep the phone numbers of the special educators and other service providers. The parents need to mobilize the local resources for experiencing the ADL activities. We need to facilitate the oral movement or the tongue movement. That is very much we need to understand and then attend to that facilitate the feeding as well as the communications. Some of the blowing activities, sucking activities, so those are all very much essential for the parents to plan and practice among the children with disabilities. That will facilitate the children to have a good breathing, and then that facilitate the feeding and the communications. The movement of tongue, so that can be manipulated or through given some activities like that fixing up certain sweet or honey or candy, and then ask them to move the tongue and take those sweets, honey or candy. So we need to provide opportunity to observe and learn the activities. So the parents need to provide the opportunity for the children to observe. That is, they have to demonstrate activities. They themselves or with the peer group or with the other siblings. They should provide the demo so that the children will have a clear observation and then imitating the activities. Use the adaptations, locally available adapted materials so that provide opportunity to explore the learning of ADLs. Some of the activities to overcome challenges in performing academic activities at home. So we need to train the various sensory modalities. So sensory modalities are the gateways for learning. So we need to equip or we need to train all the sensory modalities like visual, auditory, tactile, anesthetic, vestibular, olfactory, and gustatory. So all these senses need to be equipped. So give discrimination activities of the above sensory pathway or sensory modalities, so that discrimination has to be planned clearly. Discrimination of activities, discrimination of various senses, that need to be planned, clearly, so that the activities or the objects are discriminated in a clarity. We need to provide orientation on the directions with various experiences. So we need to provide the directions on through various experiences, like using the objects or using the persons or using no other the actions happen in the environment. We need to plan to orient the directions on all the aspects. So provide certain adaptation to hold and manipulate the reading and writing device materials. We need to provide the adaptation to the technology, so that the technology also access through that the children are enabled for learning the materials. So this AAC, augmentative and alternative communication, so we should not ignore. So that should go along with the program in the process of teaching and learning. So very well we need to use or keep the AAC program in the process of learning, so that it reinforce for learning the academic activities. Some of the materials, some of the programs are suggested, like that auditory activities from less complication to the more complicated auditory discriminatory activities, visual discriminatory activities, that other olfactory and gustatory discriminatory activities. So that should be planned from less discrimination to more discrimination, so that the clarity is learned by the children in a phase out manner. And some of the adaptations which are provided, so the adaptation can be like making adaptation in the material itself, or making adaptation in the environment itself, or making adaptation in the process itself, so that enables the children with disability, children with cerebral palsy, to access the curriculum, to access the material which is provided for the children to learn. So some of them, that images are provided for adaptation of the learning materials, accessing the material, certain materials which enable the children for them learning in a comfortable way. So with this, I open to the participant and the organizer to come up with more ideas and have discussions. Thank you very much.
Thank you, sir. Thank you for such an informative session, sir. The educational intervention for individuals with cerebral palsy at home, at the community, and other domains have been really addressed in an elaborative way. Thank you so much, sir. And now we'll move on to the next presentation. The next presentation is going to be on physical functional management of children with cerebral palsy, with a high intense information on physical adaptation at home. I'm so happy to introduce the speaker. He is a clinical specialist with more than 20 years of experience in treating babies to adults with neurological conditions. He has been teaching at various levels since 2001. And in that, I was his former colleague as well. I'm so happy to state this at this platform. And he's a qualified international NDT and BOBA tutor from United Kingdom. He is Mr. Rajkumar Rajan. So over to you for your presentation, sir. Sir? Ah,
Yeah, just 1 second. So, just getting my presentation up.
yes, sir.
Can you see my screen?
No, sir. Not yet. Loaded. Yes.
What
Ah,
can you
yes.
see? Can you see? Can
Yes,
you
sir.
see my
Yes, sir. Yes.
present?
Yes, sir. Yes, sir.
Can you
Yes, sir. Yes, sir. It is visible, sir. It is visible.
can you see my presentation?
Yes, sir. It is visible, sir.
Can you tell me? I confirm now. What about now?
Yes, sir. It is visible now, sir. We can see your presentation, sir.
Okay. Thank you. Thank you very much.
Yes, sir.
Yeah. Thank you very much once again to giving me this opportunity to be part of this program. And my name is Rajkumar, and I'm a physiotherapist, and I've been working with children with cerebral palsy since 1999. And I work with very young babies to all the way to adults who have cerebral palsy, and also adults who have stroke. So I see babies grow into infants, and then they go to become a preschooler, schooler, young adults, teenagers, and then adults. So I see how people develop over the period of years. So the topic of my presentation is physical functional management of children with cerebral palsy, focusing on home program for the parents to practice at home. Before we talk about the home program, I just wanted to highlight this definition about early intervention. So to promote child health and well-being, enhance emerging competencies, minimize developmental delays, remediate existing or emerging disabilities, and prevent functional deterioration and promote adaptation, adaptive parenting, and overall family function. The reason I wanted to highlight this definition is cerebral palsy is not just about stretching, giving passive movements from a physiotherapy point of view. And it's more than just that, isn't it? So especially when the families, they discover that their babies have some sort of brain damage, they have some sort of physical problem, that the that the child will not be sitting up, standing, and walking, eating, and drinking just like any other child, they were completely devastated. So some of them, they go into depression. Some of them, they try to neglect the child. Some of them, they become overprotective of the child. You can see all sorts of reactions. So you are not just dealing with a very young child, but also you are dealing with the family. So we in our treatment, we need to make sure that we support the family, at the same time we support the child. So it's both ways. And the way we support the family and the baby through teamwork. So here in this call, we have a team of professionals, same like that. When we address these babies and their parents, we need to address them as a team. When we talk about team, it's not team members working separately, but in collaboration with each other. That is the most important thing. So they need to sit, discuss about their goals, have a common goal that they all can work towards. That is very important. The more support we give to the family, the richer the experience that we will be giving to the very young baby. Okay. So going to the home program, why do we need a home program? Because cerebral palsy is a lifelong condition. It's not just about they come to a clinic and then you do treatment and then that's the end of the treatment. It's not like that. It's a lifelong condition. It involves 24-hour management, and most often, more than the professionals, it's the families who spend most of the time. So we need to empower the family. We need to give them enough information so that they can manage the daily life situations. And also there is a risk of secondary impairments such as tightness, contractures, and deformities. We wanted to minimize this, the development of these secondary impairments. And for the children to develop new movement skills, yeah, so they have delayed development. They are still yet to master their environment, master the skills of negotiating the space, negotiating obstacles, master the skills of dressing and dressing, master their skills of eating and drinking, master the skills of moving from one place to another place, and also sometimes moving between positions. This is all very challenging for them. And for that reason, we need a 24-hour management in place. And we also want these children to become independent. But when we talk about independence, most often what I've come across is parents want their children to sit, stand, walk as soon as it's possible. So when we try to push for independence, compromising quality, then as these children go into become an adult, they end up with so many problems. If we push for quality right from the beginning, so their future, their adult life will be much better. Okay, so what are the problems? Why we need to think about not just only the present but also about the future is because I'll give an example. 3 weeks ago, I had a meeting with a group of adults with cerebral palsy, and then when I was asking what was the main issue that you guys experience, and the first thing they said is fatigue. We never knew that we will be this tired. One day we are able to manage some of our daily activities. Next day we were not able to do such activities at the same level because they feel so tired all the time. So more than tiredness, they have fatigue, the fatigue from the muscles. It's very difficult for them to sustain the activity level. It's because they try to in their young age, the focus was on making them as independent as possible, like as quickly as possible, compromising quality. So it's okay whether they walk with a little bit of a limp, but we want them to walk independently. So such push compromises quality, and you'll be using the wrong muscles, wrong posture, wrong alignment to achieve that independence. Then over a period of time, those muscles, they cannot cope, and they result in fatigue. Okay. And the second thing they said is why nobody has educated us what are the problems these adults with CP will face. So we talk about early intervention, and same way we need to talk about educating these young children with cerebral palsy and their families what problems they will be facing when these children become an adult. Promote participation in other settings. So it's not just about doing really good therapy when they come to the therapy department. It's also about carryover of those skills into home situation, into school situation, into when they go to a park to play. So in the playground, different settings is very important. That's why we need a home program. So you all must be familiar with the ICF. So with the ICF, we should be treating the children at different levels. I mean, at the body function and structure level, or at the activity level, or at participation level. But most of them, the therapy is focused at the body functional structure level. So when we focus on body structure and function level, then our treatment involves only stretching, and it becomes exercises. It becomes, you know, strengthening, and it stays at that level. So if we focus at the activity level, and then promote their participation in the activity level, and then if needed, then you address body structure and function for that specific activity. So by focusing on activity, it's easy for them to participate. So if we target at the activity level, it will be really useful. Yeah. So just to give an example about three different levels. So the impairments of body structure and function, for example, if a child has got spasticity in the arm muscles, the biceps muscles, um, so what, and then often spasticity does not come alone. Because of spasticity, the muscle stays in a shortened position for a long time. When the muscle is in a shortened position, then the muscle fibers, they also become very tight. They get stuck to those shortened position. Then it results in tightness. Then what, this is the structural problem. So what is the function? What function is going to be limited? The function that is going to be limited is not able to straighten the arm. So this is the body structure and function. If you see here, the treatment will be at this level, in putting Botox or stretching the biceps muscle, and then uh, encouraging the child to straighten the arm. So that will be the treatment at this level. Now let's go to the activity level. So activity level involves reaching objects, pushing arm through the, like when the child is dressing, pushing the arm through the arm sleeve is also an activity. And pointing to objects, like the child is communicating to someone, pointing at a certain object. So you could see that is the function level. So here, this is the level where we need to be treating these children, and also training the parents to treat at this level. And if needed, only if needed, they need to do some stretching specifically for that muscle as a preparation for this function. Then we should promote that. Okay. So what is the participation level? In the participation level, by working at the activity level, we are enabling the child to participate in eating and drinking, not just in isolation, but also with the family. And we are enabling the child to be able to throw a ball in the playground. We are enabling the child to be able to write in the classroom setup, or for writing an exam, and all those things. Okay, these are the three levels. What are the key principles that we need to keep in mind when we set home programs? Definitely not this. So not giving too many exercises, or not just giving exercises for parents to practice. They are not expert, they are not professionals. So we need to make sure, we don't give them a list of activities to practice. And it's not possible. They have a family to take care. They have if you take a mother, she has a husband to take care, and then she may have other children to take care, and she has a house to manage. On top of this, they have this child to take care. Okay, so we need to make sure we don't just give them a bunch of exercises. Maybe one activity, or maximum three activities. That seems to be very practical. Like when we did a little bit of research about the number of activities that is beneficial, or number of activities they were able to practice at home, is they came between 1 and 3. So what activities to choose? How do we decide what is the best activity? So it depends on the parents' current concerns. So often parents, when you ask them, what do you want your child to do? Sit, stand, and walk and talk. So they are all more long-term goals, isn't it? So what will help now, today? And then we have to dig deep a little bit in our interview with the parents. And then talk about daily activities, and then participation, and then the more we try to explain about day-to-day activities, then the parents will be able to choose a specific concern that will make a dramatic change. For example, this child may be having difficulty to eat and then they may be spending more than 40 minutes to feed the child. And maybe that's where we need to start addressing our treatment. And that could be a place that could make a dramatic difference to 3 times a day, feeding the child more than 40 minutes will have a huge difference to their quality of life. So it's important what activities that we choose. Give opportunities for parents to practice the activity under your supervision. Not just recommending and not just showing, but we want the parents to practice the activities right in front of you. Whether you are going to recommend parents to help the child to move from one position to another position, or whether it is helping the child to dress, undress, or it is you're showing a different way of feeding, we want the parents to practice, do it in front of us. Okay. And make it as easy as possible. If it's not easy, definitely, the parents will go back to their own way of helping the child. Okay. Make it as easy as possible and make it feasible. So when they come to clinic, you may have all really fancy equipments, and then you may use those equipments to treat this child. But all those things are not available at home, isn't it? So you need to be considerate and then discuss how this can be adapted to the family, the home situation. Make it really enjoyable for both parent and child. Not just only easy, but also fun. So, and motivation is key, isn't it? For them to, if you give the right reason for the parent, they would definitely try to do it. Okay. And consider different learning styles. Some parents would like more detailed explanation, and some parents like to do it. Some parents would just want to watch you do. And some, if it is possible, allow them to take photos or videos so that they can go back home and then watch and then practice. Okay. It's not just mother, it's father, it's mother, it's siblings, it's grandparents. You need to create another team at home, so they all should be aware what is being said to them, what advice has been given. So you say, for example, only the mother comes to therapy sessions, and then you give some advice, and only the mother tries to do that, and rest of them, they may try to, like, for example, let's say you advise a specific way of lifting and carrying the child, okay, and the mother is trying to practice that. But when the grandparents come, or when the father comes, or anyone else visiting the house, they would just pick up the child in any way that it's possible. But that's not going to help. And that's not collaborative approach. And there will not be any carryover. If for the child to learn something, there should be carryover. Okay. What I mean by carryover is whatever positive effects that we get from one activity, and that positive activity, the effects needs to be carried to the next activity. And that is possible only from a team approach. So the carryover of positive changes is very, very important. Why it's important? Only through that carryover, learning a new skill is going to happen, isn't it? So when you learn to drive a car, like for example, the instructor is going to teach us how to turn left, okay? And then you practice turning left. And then when you come to the next session, then there is no opportunity for you to turn left. Then the instructor is asking you to turn right, okay? So then there is no carryover, isn't it? But when you come to the second session, if you have opportunity to practice turning left few more times, then it's easy for you to remember, and that is going to reinforce your learning. Same way in children with cerebral palsy, we need to make sure there is carryover from one activity to another activity, carryover from the treatment session in the therapy department to the home situation. So we need to think about carryover. Therapy should educate parents about the treatment principles. Sometimes what is possible in a therapy department is definitely not feasible, not practical in a home situation. So in that situation, the best thing what we can do is we can give them the treatment principle. Okay. So most often the parents may be dressing the child in lying position. Okay. Then you say, you dress, maybe you say like you always put the left arm into the sleeve first, and make sure you do that in sitting position. So then the parents, being the expert of their child and environment, then they may be able to adapt your what you have shown, because they understood the principle. They understood what is the principle behind that recommendation. Then they will be able to adapt it to their home situation. So the principle is really, really key. Make them understand why this activity is recommended, the reasoning behind the recommendation. Okay, I'll give an example. Like you could see in the picture here, a child with who is standing with both the knees touching each other. So both the legs are turning inwards, and then now this child is starting to stand and walk but falling very often. One of the reasons the child is falling often, because this both the legs are turning in, and because of that there is increased tendency for the child to come up on toes. When the child come up on toes, then the base of support reduces and the child becomes very unstable. Okay, so here then the recommendation was to give the nice orthosis for the child. Okay, but when you give the orthosis for the child, that means you are giving a nice base of support, you are stabilizing the ankle, but you are not still doing anything for the turning in of the legs. Okay, then the therapist suggests the parents something that they have to do, like this, like they use a strap to support the to go around, it's called derotation strap, to go around the thighs so that the thighs are not turning inwards. So the thighs are turning outwards. That way, there is space between the thighs. Okay. So now these are two different, like this has really happened. Okay. When I made these suggestions to the parent, the child already had orthosis. Then I just told them to, there is a place you can buy these straps, and then this is what we need to do. And the reason is I explained everything to the parent. And then I see this parent after 2-3 months. They come back. Okay. So what they have done is they, with their creativity, they just combine these two, because what they did is they put a little pin, they attached the lower end of the straps to the orthosis, and then they combined these two, and they came up with this beautiful idea of, as soon as they put the splint and then they put the strap around, then it's both these two different equipment, they are now working together and helping the child. So the child was able to stand and walk and also maintain balance without falling because of just simple adaptation. And who came up with this idea? It's the parent. Okay, this happened many like 10 years ago, 10-12 years ago, and after that this concept became very famous. So the reason the here what the information I gave is the knowledge, and then the principle behind, and the creativity came from the parent. Okay, because it is much more easier when these two are attached. Practically it's much more easier for them to apply. So that is the power of explaining the treatment principles to the parents. Okay, so what can make a home program effective? There are certain skills that we need to give to the parents. One of them is basic handling. When we teach basic handling, and then choose one or two specific activities of daily living to focus on. If you show them how to dress, undress, how to feed, how to play, and all those things will be just too overwhelming to the parents. So maybe just one skill at a time, one activity at a time, and on top of that, give them basic handling. I'll explain what is basic handling in a moment. So when we do give basic handling and focus on one activities of daily living, then there's more chances there will be good carryover. And when there is good carryover, then learning of new movement skill is possible. Okay. So basic handling. Basic handling involves how to lift the baby from the floor, how to carry the child, or how to position the child, how to help the child to move between one position to another position, and how to help the child to transfer from one equipment to another. For example, sitting from a wheelchair to go and sit in another chair or a sofa, or from the sofa to go into the wheelchair. So transfers. So basic lifting and carrying, positioning, transitions between positions. What I mean by transition between positions, like floor to standing up, or lying to sitting up, or from sitting to quadruped position, crawling position. So helping the babies or children to move from one position to another. And then the transfers. Transfers is between one equipment to another equipment. Then we talk about specific handling. Specific handling, we spoke about basic handling. Now specific handling related to one activity of daily living. Okay, not so many. Okay, so let's say the daily life situations could be feeding, dressing, undressing, nappy changing, giving bath, play, making the child to go to sleep, all those things. Okay, in those you're going to choose one, and we're going to address one thing. Okay, so here are some. I just want to give you a couple of ideas, and then we'll see. So if the goal is to improve rolling, the child is not at rolling, and then we want the child to learn to roll over. Okay, so what parents can do? Parents, like if they want to lift the baby from the floor, instead of just straight away lifting the baby from the floor, they could roll the baby to one side before picking up. So that means they're giving an opportunity for the baby to roll over, to a change in position, instead of from supine, from lying on the back. So you helping the baby to turn to one side and then pick up. Why that is important? Because when we sit up, when children, they learn to sit up, they always turn to one side and then sit up, isn't it? So we are trying to help prepare the child for an higher level function by doing this. At the same time, by doing this, you are also helping the child to improve rolling. Okay. And now what about placing the child? So this is for picking up. Now the mother is carrying the baby, and then they want to put the child to lying. Instead of putting the child straight away to lying on the back, you put the child in lying on the side, so the child gets an opportunity to roll onto their back. So the another way to do it is to place the child down in sitting, and from sitting, then the mother can help the child from sitting to go into lying position. So that is also, so the lying, from sitting to lying, it could be going to side lying, or even the mother can help the baby to go from sitting to lying on their tummy. So that means rolling over from sitting to rolling over. So that is so they may be picking up this child or placing the child down maybe 5 to 6 times in a day, or it could be more than that, or it could be more than one person doing it. So each and every single time, if remember to do this, just one simple adaptation, then the child will learn to roll over much more easily, isn't it? So we will be teaching them how to move between positions, isn't it? That's the basic handling. So you will be teaching them how to do a complete roll, but also asking the parents, think about the daily situations, like each and every time they lift or place, bring that principle of rolling. That's all we are asking the parent. And we should be just focusing on that skill. And in that way, it's much more easier for the baby to learn that skill, the parents to easily manage the therapy principles. Okay, I'm going to give you another example. You want the child to sit independently. You won't touch it, because when you place the child in sitting, the child is not able to maintain sitting. Okay, so how can we address this? Sit baby before lifting up. Before we spoke about, before parents are lifting the baby, we encourage rolling to one side to pick up. Now we are trying to roll to one side and then sitting the baby up before picking up. Okay. Place baby in sitting before lying down. Same thing, same principle like I did before. Place the baby in sitting and then going into rolling position. Each time you do, you are encouraging the child to actively arrive into sitting. Okay. So what parents and therapists often they do is they place children in different positions. By doing that, the child does not get an opportunity to learn how to arrive in a position, how to move out of a position. But this is the best way to achieve that. Okay. And the child will also now become ready. How they become ready is they know, when the mother is going to lift them up, that means they are going to move from a lying position to sitting position. Then the readiness will be there automatically. So the parents, instead of doing dressing, undressing, and lying, the therapist then show the parents how to take off the top in sitting position. Then automatically the parents doesn't have to do anything separately in sitting. So this is, it's part of the daily life. They will be changing clothes at least once or twice in a day, isn't it? So use that situation to address therapy. So then instead of doing it in lying, they can do it in sitting. What about feeding the baby or encouraging the child to eat in sitting? Most of the parents, they do encourage the child in sitting, but when younger the child, then they have the child sitting or lying on their lap. Most often lying on their lap when they feed. But we need to start encouraging them to, like 6 months or over, is better to have the baby in sitting and feeding them in sitting. So that will help them to develop that head control, help them to develop that tongue control automatically. Whenever they play with, and whenever if they are when they are interacting with the baby, they can interact with the baby, supporting them in sitting. So that way, sitting is being reminded in different situations of daily life, rather than practicing sitting separately as an exercise. Okay, this way we are making it easy for the parents to achieve certain milestone and for the child to develop a new skill. I said this so many times, I'll say it again. Choose one skill at a time. And say, for example, you chose this sitting, the one that we discussed just now. Focusing on sitting and practice, give them opportunity to practice and focus on sitting for the next 30 days. You will definitely see a dramatic change in the child's ability to sit independently. At the same time, you might see the parents' willingness to achieve that milestone, help the child to achieve that skill will also increase dramatically. In 12 months, the child would have learned 12 different skills. I'm not saying in 12 months the child is going to sit and stand and walk. It all purely based on the individual's capacity, the potential to change. But I'm not talking about gross motor skills alone. I'm talking about as a whole. It's whether it's gross motor skill, it's fine motor skill, whether it's eating, drinking, whether it's communication, whatever it is. Yeah, one skill at a time will make a huge difference in their life. That's the end of my presentation. If you guys have any questions, I'll be happy to answer.
Sir, thank you for your presentation, sir. It was really a scholarly presentation along with the exercise, which would really be useful and meaningful for listeners as well as the parents who would be their beneficiaries. Thank you so much, sir. And the QA session will be after one more presentation,
Okay.
during which I'll be able to share the questions. The YouTube link has been shared for the participants. So questions have been collected and I'll be presenting the questions. Maybe you can join us in answering to that, sir.
Sure.
So I request you to stay online
Yeah.
till the next session would go up. Thank you, sir. Thank you.
Thank you.
We'll move on to the next session. The next session is about activities that promote communication in home situation. We have Srimati Kalpana Rao, the principal and head of communication department of Vidyasagar, an expert in AAC and has conducted various training programs on AAC.
A very good afternoon. Am I audible? Because Anusya, please confirm whether I am audible.
Mild audio disturbances. So that's what I just took a break in introducing you. I'm sorry, ma'am. Let me introduce you to the
Yes,
listener.
It's audible.
Yes, ma'am. Yes.
Okay.
Yes. Thank you, sir. Yeah. I just want to say a few words about the speaker before she starts. For the participants to know about her, she's an expert in AAC and has conducted various training programs on AAC in Vietnam, Sri Lanka, and Oman. Many papers in international conferences on AAC. She has been the Secretary of International Society for Augmentative and Alternative Communication, India chapter, and has been a faculty for AAC for the certificate course in Assistive Technology Solutions held by NISH. She holds a qualification of Masters in Psychology. Ma'am, over to you, ma'am.
Thank you. It was a wonderful presentations. The people who have presented before me. My presentation is on augmentative and alternative communication and simple strategies for parents to follow at home. Because due to COVID, we all know we are all stuck at home, but that doesn't mean that the student or the child is going to lose out on the communication, which is a basic need for any of us, and all of us are social animals. We want to communicate with each other. Just like that, our kid, our child with cerebral palsy will also want to communicate. So I made a small presentation with telling about what are the needs and how we can go about doing it. I'm just going to share my screen now. Anusuya, am I audible?
Yes, ma'am. Yes, ma'am. You are audible, ma'am. Ma'am, I just, ma'am, just information, ma'am. Is there a fan that is on nearby you?
Yeah, I'll just do that. Is it better now?
Yes, ma'am. Yes, ma'am. Thank you so much.
My screen is still showing Mr. Rajkumar's screen as thin. Can you share the screen from yours? My presentation from your screen?
Yes, ma'am. Sure, ma'am. Sure, ma'am. Sure.
Yeah.
ஸ்க்ரீன் ரிப்பீட் நீங்க பண்ணோம் பண்ணிட்டீங்களா? Ma'am, the PP is presented, ma'am.
Yeah.
Can you see the presentation?
Yeah, I can see.
Yes, ma'am. Yes, ma'am. Please.
Okay. So we are going to discuss about strategies for promoting communication for people with complex communication needs. Now, can you please change the slide? Anusuya, please change this. The one premise which we all start with is everyone has some, that means every human being, however profound disability they may have, or they might, everybody will have something to say. And that is one premise and one belief we all start with. Please move on. To start off, I wanted to say what is, in simple words, what is communication? Communication is a simple act of transferring information between two people. It could be from one person to another or from a group to another. The complex communication need refers to people who are unable to communicate because only with speech. So please move on. Click to the next. Yeah. So in that context, I thought it will be easier for us to figure out where are the problems lying in the communication. Whether a communicator, that is a person who trying to communicate, is having a problem, or is it in the process, in the what he wants to communicate, it is the problem lying there, or how is that the method in which the person is trying to communicate is the problem lying there, or is it a problem with the communication partner? Because all these 4 components are very important for a communication to happen. I can see in the screen. Anasuya, I'm not able to see the screen. Do you want me to try and present now?
Just
You
give
know,
us a minute.
yeah,
Give us a
yeah,
minute, ma'am. Yes.
yeah.
The inconvenience is due to the technical issues, ma'am. We'll be shortly displaying it, ma'am. Give us a
Yeah,
minute time.
yeah, no problem. Can you see the screen now?
Yes, ma'am. Yes, ma'am. It is visible, ma'am.
So can I continue from here then? Because I am
Yes, ma'am.
putting it from my system then.
Yes. Yes, ma'am. You're most welcome, ma'am. Yes, ma'am.
Okay. Thank you then.
Can you go
Yeah.
for slide show so that it will be maximizing with its presentation?
Yeah, I'm trying to do that. Yeah. Just tell me if it is not visible to you, because here I can only see my slide. Okay?
Yeah, we can see the slide, ma'am. Yes, ma'am.
So I'm
Yes,
sorry, sorry about the confusion here. Ultimately, anyway, it started from my system, so I'll just start from here. So the premise, as I said, we all go from the premise, and based on the belief that everybody has something to say is something which I believe personally, and we promote and do that. Now, as parents and family, this is something which is something a child is very happy to communicate with a parent and a family, because parents are natural communicators. You know, as a parent and as a family, what your child needs, how they are trying to communicate. You understand the child the best, and of course the children are also very confident and comfortable with their own family and parents. So in my opinion, there is not extra a training a parent needs, but a training to understand where a child, their own child, is standing in the per se of in the degree of communication which we call as, and see whether how best they can help their child to move further on with communicating independently, because that is the main focus we will be looking at. This I have already done, what is communication and what is a complex communication needs. I don't want to repeat that again. So here we were when we just lost touch. So communication involves who, what, how, and to whom we are communicating. So at this present point, we are looking at our child as a communicator, and what the child is trying to communicate, that is a content, is called the what to communicate. And the method, it could be a gesture, it could be sound, it could be using a picture, it could be using a word. That is the method of communication. That is what we call as a how to communicate. And the communication partner, it could be the teacher, it could be, right now it could be a parent and the family members, who are the most important partners in a communication, because any person, if you have to communicate, you need a partner. Only then a conversation can be built. Now, with our children, the communicator whom we are discussing, there could be many difficulties because of in neurological impairment. There could be for cerebral palsy, they could have speech difficulties, they could be having vision difficulties, they can have multiple disability with the hearing loss, they could have difficulty controlling the muscles, so because of that their speech is affected. They can also have motor limitations, which would actually hinder in their signing or a gesture, or sometimes in the facial expressions. So that is where augmentative and alternative communication steps in. What is augmentative and alternative communication? It's just a blanket term we use for any form of communication. What I said, it could be a gesture, it could be vocalization, it could be a picture chart, it could be sight words, it could be words written anywhere, or a combination of all these. That is something which we can use other than using a direct speech. Now, the single objective of augmentative and alternative communication is to get an active and full participation of individuals with complex communication needs. When I say active and full participation, it is active is the child is a part of a conversation, and equal participation is given to, if there are 3 members conversing, equal participation is there with all the 3, whether the child is verbal or non-verbal, that is different. So what I thought would be a best thing for a parent to understand is what are the communication demands, opportunities, methods and supports which a child, a person with a complex communication need would need to make to go further, to step ahead and do a independent communication. So I'll be taking through certain those 4 steps, but before that, I would just like to say there are certain non-negotiable things which we have to have as a parent, whether it's a teacher or a parent, it doesn't matter, which situation doesn't matter, which environment doesn't matter, but the position of the child, position of the person who is trying to communicate is the most important thing. So that is why I said position, 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 because that is the first and the foremost thing to do. The person has to be in a comfortable, supported well in a wheelchair or a chair or whatever they are sitting, so that they are able to use their body to the best of their ability. We have to understand augmentative and alternative communication relies a lot more on their body. Either it could be their hands or even the vocalization, or sometimes they might be using their eyes to communicate. In such things, it has the child or the person who is trying to communicate should be very comfortably seated. The second thing, very important thing, is to sustain the position to access and use AAC for a period of time. We really cannot think about, say, if the child is comfortable, if they're just able to sit and maintain the position for a minute. To communicate, you need a long time. You need to hold the conversation. You need to sustain a conversation. So the position has to be done. If you need to use straps, if you need to do some modifications, that has to be done, because it is not as if the child or the person is not trying to communicate, but they are trying to communicate, but because of the lack of sustaining the position, they might be losing out on the communication part of it. And also maintain the position without getting tired. The fatigue part, the position they are using should be a very comfortable position that they will be able to continue the conversation. The other important thing also I was thinking is, if I cannot see you, I may not think to talk with you. It is not saying that it is visually seeing. It is being in the presence of the group. If we are having a conversation in the family and the child or the adult who is using an AAC is in the next room or away from the conversation, they are not going to be part of it. So it is very essential that the person is in the middle of the place where the conversation happens. And also a really important thing, upright position always allows full interaction with the world. It also helps for the parent or the therapist or a teacher to identify a reliable voluntary actions, which can be then used to for the mode or the method for communication. The other important thing I would mention to the parents is look at the visual capacity of your child. Is there any problem with the visual capacity? Do they need a high contrast? Is there too much of a clutter and the surrounding areas that it is distracting the child? Is the communication chart, if you are using, or if you are using an object, are they well spaced? Is there a high contrast? That means maybe on a black paper or on something contrasting, are you able to say, so that the attention is on the thing or the object to be communicated. Also make sure there is a good lighting in the room and there is minimum amount of reflective surfaces, because a reflective surface is many a time a lot of vision, a distraction for children. Now, again, coming to the physical ability, how is the child going to access? There are these are the technical things. There could be a direct selection, just like in the picture I'm showing, there is a person just pointing out to a glass or pointing to a picture. These are all called direct selections. There could also be a person who is here in the third picture using a eye gaze technology, pointing with their eyes. You might have any other pointer like a pencil or something in the hand to point. These are all direct selections. When it comes to high technology, which I'll be doing a little later, you will be having a sort of a switch. Switch is an adapted mouse, or it could be also on a scan mode to be used for children with high support needs or complex communication needs to use the technology part of it, which I will be doing it a little later. Now, as parents, we need to understand where is my child at in a communication spectrum. The children could be at an emerging communicators. That means they are just starting to communicate. They might have a communication intent. That means they know that they have to communicate something to get something, or they are still at a spontaneous behaviors are there, and which as a parent we are understanding and giving it a symbolic meaning to that, and we are trying to understand and give it a meaning. Many of our children with complex communication needs might be still at a spontaneous behaviors, which a parent or the teacher or the communication partner is understanding and making it into a communication channel. Again, they may not be having any formal mode, so probably the child is at a very basic levels of communication. They might be very dependent on a familiar partner to communicate, because as I said, could be spontaneous behaviors, there could be communication intent, but no formal mode. So they are very familiar, very comfortable using a familiar partner to communicate. Now, what are the communication demands the child has? That is what we call as the functions of communication. The child might be wanting to greet or express, say thank you, ask for something, refusing to have, saying no, I don't want, or just to get attention. The child might be using, these are the demands. The child might be using communication in these circumstances to communicate with a partner. Now, how can we help this child to communicate better? Simple thing is, as any parent would do, is to manipulate the environment. Just keep those things which the child needs or the person needs away from it or out of sight, and make sure the person asks for it. You may not have to use a communication chart, but just to put a hand forward and ask, or make a sound to ask, or look at it and look back at the communication partner. Take all these as the communication methods the child or the person is trying to do. So take it, accept it, and start working on that. You can even give a wrong thing because you want to move the person or the child from one level to the next. Maybe he's asking for a ball. You will try and give him a glass of water. That is not what the child needs. Then there is a demand for the child to say, no, this is not what I want, and point to something what he wants. So that is how we need to create opportunities so that the child is able to move ahead and come to a place where there is a formal mode of communication. You can even ask open-ended questions. Instead of saying, do you want water? It would be only saying yes, or taking the glass of water from the communication partner, or just saying yes or no, or rejecting. But if you are asking, what do you want to drink? It could be milk, juice, water, and those can be presented as objects. You can have a glass of milk or a glass of water, a juice or a fruit in front of it. You don't need pictures at this level. Just give them objects, because here we are trying to make the child have a formal mode of communication. There could be many things. Here in a picture, I'm showing the mother communicating with this child using simple tactile system. Actually, these are tactile things which the child is having on a high contrast chart, and the mother is asking the child to just point to whatever it is. If you have a technology, high technology, you can use things where you have a recorded messages, which I'm showing. The red one is called a Big Mac, where you can record it, pre-record whatever the message you want, and the child can touch on it, and the auditory feedback comes out. So these are immediately you get a gratification. The child listens to it, understands what he had made the choice, and then we can move further up. So we can have the one which I'm showing on the black one, which is these are all objects of reference, different objects of reference which the child has already understood and started using. You can make and stick it up on a piece of black sheet. These are objects which are available. You all have to do whatever things are available, you can stick, but introduce that to the child. Start asking the child to use it. So this way we can increase a lot of rich experiences can be there. We can move him towards a symbolic vocabulary, because here there is a direct communicative purpose. If the child is touching on this pink thing, that means, okay, he wants water, then he touches that. It is becoming a symbolic communication, and we are moving towards a formal formal method of communication. You can explore even a range of communicative functions using these things. I also was looking at, if you have a simple laptop, what else you can do to make your child have more vocabulary. Here I'm trying to show you a small thing which I made with a PowerPoint presentation. It is just getting one word at a time with an audio. I'm just trying to play that. This is a story of a hungry dog called Tummy. Now, what is it that we are doing? We are getting the visual scanning here, the word by word the child is getting to read. There is an audio. You can record the mother or the father or a family member whose voice the child is familiar with, can be recorded into that. You can add pictures, you can because most of the households, if you have a laptop, if you have a PowerPoint in it, we can create this. There is an audio and a visual scanning which is needed. This training is needed for our child to go ahead and start becoming independent in using the communication systems later in the life. This is again, we have been hunting around for many storybooks which could be made accessible. I'm trying to do this. The importance of why I'm telling these are to train the child to become independent in learning, getting information from outside world by himself. So we have to look at many things which the child can do. I'm just moving it forward. Now foundation, and this is the book which I was just.
All our stories come with these accessibility features. You can use the audio read aloud with highlighted text in 3 different ways. Amma makes me warm things to drink. She makes me special food that is easy to swallow.
Why I want this is there is already an audio storybook with a highlighted word which your child can focus on. You can minimize the volume, increase the volume, whatever you want you can do. But this helps the child in going forward into the next level. Now, we also have to look at children playing. We can use adapter. Here is a winner VBOS, which I'll be explaining later. Simple toys, the motor, the battery operated toys, which a child with cerebral palsy finds it very difficult to activate by himself, or in a small switch which is not able, which a child will not be able to do. So what we do is increase the surface by giving it attached to a switch so that there is an independent play. Now, as a child plays independently, or as a person plays independently, there are chances for more conversation building, more emotions being said, more adjectives like wow, very good, you played it. So much of conversation can happen during the play. There are also many things available now. It's called switch based free to download games. If you do not have a switch is something called a mouse, is something which our children will not be able to use because of their limited motor ability. Now, how do we get the child to use a computer, or because everybody is using? If you have a technology at home, let the child use, let the person with disability use. So what we have in the left is just take a small cardboard box, fix something. It could be a eraser, it could be a metal like a sharpener or a nut like this. Make sure this will, when you close the box, it lands on the left click of the mouse. Keep the mouse inside. You can see the mouse inside. They are putting this so that when they close, it just comes and lands on the left click, the place where the left click of the mouse. Now, when you close, this box becomes a switch for your child. All the child has to do is tap it on that, and this connection, this point which we added here, will sit on the left click part of the mouse, and then the child will be able to access things on the computer. So this is a simple technique which you can use for your child to use not only the games or the switch-based games. You can start using your the paint options in your computer. Now, coming to the fourth thing is the communication partner. At this point of the time, when the child is at the emerging communication thing, the child, the family, and a close circle of the friends are the ones whom we need to increase. We already have the family because, as I said, the emerging communicators are very comfortable with their family. Now, the circle which we are increasing is the friends. It could be same age friends, it could be neighbors, it could be anyone. Now, how do we, what is, as a communication partner, what is it that I need to do to make my child communicate properly? It is one, do the modeling. Please use those charts with your child is using. Please use the objects which the child is using as you are speaking, because that is the best model for your child to start using the communication system. Remember, we wanted to move the child from there is a no mode for communication to having a formal mode. So start using. The next thing is the wait time. It is very important that you give the time. You can't go on be saying, do this, you touch this, you do this, you show me this. That doesn't need. Tell the child, pause, wait expectantly till the child is doing. Whatever the child or the person has responded, give a positive reinforcement. Yes, continue, you can expand, and you can take to the next level. The next second level of communicators, I would say, are the context-dependent communicator. What is a context-dependent communicator? In lay terms, I can say, today if you are going to a park, you're playing with something. In that situation, the child knows those objects, or the person knows those objects person knows those vocabulary and he is able to communicate at that level. For these people, for these children or the persons who are at a context dependent, you may not be able to communicate, ask them to communicate about certain things which are not there in front of them. So it is very much as a context. In particular context, they are able to do, and related vocabulary to the context presented in front of them, they are able to communicate. But then we are trying to move our child to become increase conversation. Communication is not just responding. Communication means conversation. So how do we make this child to get into better conversation skills have to be learned, and we need to converse. So now that means this particular child who is at a context dependent communication, they might be using tangible, tactile things as for communication, or might be using picture. These are all symbolic, augmentative and alternative communication system. They are very successful in that context of communication. If you are asking about whether you want to have a breakfast of idli, dosa, whatever it is, and in that is a context, the breakfast is a context, and the child might be able to successfully be able to communicate with you. And they are also better with familiar partners. What are the communication demands? We want the child to do a little bit of sharing the thoughts. Yes, he might be doing in that context, but outside the context, there may not be there. Express emotions. Yes, they might be able to express emotions in that particular. They would say, I'm happy or I'm upset about that. But pertaining to that context, they may be able to make choices and they will be able to assert independence in that context. They will be able to comment also in that context. There are other communication functions like giving and getting information, also to direct other actions. That means controlling others. The child or the person should be able to say something and to do that. These are also in that context base, our children will be able to do that. Now, here for these communication opportunities for a context-dependent communicator, we need to depend upon what is a vocabulary we are providing for the child. Whether there is a core vocabulary that is a frequently used vocabulary, fringe vocabulary, once in a way what we are using is called the fringe vocabulary. Concentrate on the core vocabulary. That doesn't mean that we are not using fringe vocabulary. We do introduce, but the child should be able to access the core vocabulary immediately. It could be objects, it could be tangible system, it could be words, it could be pictures, but the core vocabulary has to be made available to this child. Now, how do we do? Now we are all stuck at home. I think making a communication system always available is the first and the foremost opportunity for the child. You don't have to have, if you are traveling, you can't say, I don't have the communication chart. Just the stick charts, the stick notes which we can do, or a small sheet of white paper. Always I tell the parents, have some white papers in your bag and a pencil. Write it, introduce to your child and start the child to do. Don't have to think whether my child is able to understand this. Right now, we are looking at the communication opportunity. The child has to point to what he wants. So use paper-based AAC. If you want, if your child has a little vision issues, use a black sheet. Just a black chart paper should be able to give you the high contrast needed. The communication should happen naturally and easily is something which we have found also very successful with our students being able to communicate. Even in the cooking, when you are cooking at home, just use those vegetables to communicate. Ask the knife or a spoon to ask whether you want, should I cut, should I scrape? These are natural environments where the child will be able to communicate. If you are able to do a picture, use the picture at that point. If you are able to write it, write it. But a successful communication will always when it is in the fastest mode. If the child is able to point with eye as a fastest, take it. If the child is able to use the hand to point, take it. That is called the mode. The fastest mode is the best opportunity you can give for the child or the person with uh, complex communication needs. Now, if you are a parent, if you feel I don't have, if you have, when you have time, just make those grids. The grids give them a, there is a structure to it. If your child can only see 2 per sheet, create the grid. You can add any picture, you can add word, anything, or you can even place an object on that. That gives the boundary for the child access, because when you're creating a grid, you know the physical ability. Okay, this is the place my child can access, this is the place my child cannot access. So create the grids according to the physical ability of your child. Keep these ready for the usage at different times. Now, there are many high-tech devices which are available. When I'm saying high-tech, these are not electronic. These are electronic devices where, or they are all only with the battery-operated things. These give voice outputs. This Kathamala, the yellow one, is available with the Indian Institute of Cerebral Palsy, Calcutta. The Go Talk is available online, or you can just use a picture chart, a printed picture chart, or a line drawing picture chart. iGest is a communication device which is being developed. It actually, when I said when a child can do a gesture by lifting a hand for water or saying no, this converts the gesture into a voice output. So that makes communication between the same age peers better. You have a Gupshup album. Again, you can insert a picture into that or an object into that and record the voice so that your child will be able to use it. There are many high-tech devices. These are high-tech devices like Avas, a downloadable Kavi PTS. It's available on the Google Play. Sanyog is in Hindi. Jello is done by IIT Mumbai. Again, a Gupshup software from Calcutta. These are all things which are available online, which you can try and get for your child to use. Kavi PTS and Avas have been done by us at Vidyasagar, and Kavi PTS is a free download. It gives you a minimum number of pictures and very easy for a parent to do. The plus point, it is free to download. So any parent who is watching this can just go ahead and type Kavi PTS, download and start using it. The advantage of these things are there's a access to vocabulary, there is a voice output, it's a picture-based communication system, you have a scope for conversation, it is portable, you get it in multiple languages, you get it in Tamil, Hindi, etc. Very user-friendly. Any parent, you don't have to be a special educator, you don't have to be a technologist, you just can do it. Now, this increases peers and siblings' curiosity. Now, again, coming back to the access. Yes, as I told you, you can have the mouse converted with a box and can use it as a communicator for an access. We also have Aditi, which is a movement sensor switch. The child need not touch it. Just move the hand just 6 inches away, hand or leg, and it starts working as a left click of the mouse. Now, with this, why am I saying use these things is because there are many audiobooks available on the net. There are PowerPoints available. These give more information. Your receptive language, that means the knowledge of the child is increasing by listening to this, accessing all this. Because to communicate, I told you in the starting itself, what is a what is a child trying to communicate? That is the content. The content will increase with more and more exposure to language. Winner and VBUS or switches developed at Vidyasagar. It's a plug-in and plug-out switch. Its purpose is the same. If you don't have to use if you are unable to use with the mouse, if you are not able to do, you have better hand function than using the Aditi, you can even use it as Winner VBOS, which is a touch device. Now, as I said, the content we need to do. just with the clip arts available on the net, you can create sentences with pictures so that the child is able to access, understand. You just give a voice, recording into your PPT saying peacock is our national bird, and peacock is one of the most beautiful birds. This increases, there is a attention to the vision, the visual clue which you have given, the pictures. There is an audio coming out which will integrate and take the child to the next level. You can even do evaluations just with the same communication chart. You can ask, what is your national bird? Just create a small pictures as a grid and ask the question so that the child has a number of choices to give you an answer. Now, at this point of the time, who is a communication partner we are adding? We are already added family and friend. We are adding acquaintances. That means few times acquaintance is not a familiar person able to come, maybe better than a stranger. Acquaintances, paid helpers, caregivers can be added to this level. Now, how can these communication partners help? You have to respect the communication done by the child. Slowly give a prompt. You can say, can you use this your chart to answer? You can tap on the chart and say that is a gesture we are giving, or a prompt we are giving for the child to use a communication system. You respond very well to the child, acknowledge and appreciate the participation of the child. Expand whatever. If the child has said in one word, expand it into a sentence and say, yes, this is what you, this whatever it is. If they just say ball, oh, you want the red ball. If he says water, okay, you wanted water, you want, so say, Raj, you want the water. So that restating in different ways and expanding helps the child to get the language development needed for a conversation building. Now, coming to the older kids, older, or it may not be older, or a communicator who is not very context based communicator. These are independent communicators. They are successful communication. They can communicate with unfamiliar partners. They already have established AAC mode. They might be having good spelling or reading skills, and they are comfortable using their communications. Now, what are the communication demand for these people are? They, because of their communication and their functions, they can give information. They are able to control. That means they can tell something to us and we are able to do what they want. They are able to give the emotional expression is in place. They are highly motivated to use those functions of communication. All these we need to do the social connections to increase the number of people with whom they are able to communicate, which is needed for having a supportive environment in their family, with their friends, in an inclusive society. We need to have a supportive. So for them, what it is, having a good vocabulary is the most important thing for a good social interaction. We try and give, yes, if they have communication low-tech charts with line drawings or with pictures, you can use them. If they are having alphabets, they can do that. If they have AVAs, which is a portable communication system, which I mentioned previously, they can use. What is it they have? They can have word prediction is available. They have a built-in language. If they choose one word, the second word is already coming up. So the sentence construction becomes easier. They have a voice output in that. And they can access large vocabulary, whether it could be picture or it could be a word data. And there is a scope for conversation building. Alongside, we also have to use the other technology available in the right now. We have adapted keyboards, we have adapted mouse. I'm showing you, which depending upon the access the child can do, we can use. There are online calculators, there are talking clocks. The Paint has many different types of, for iPads, you have Doodle, all that, which will help the child to using technology, because at this point of the time when they are comfortable independent communicators, move them to become independent communicators, independently, because that is a way forward for. We are not only looking at communication, we are trying to integrate the technology so that the person is getting better and starting to move towards a vocation, because it's a lifespan. Just communicating is not enough. We need to look beyond communication, trying to get them to use the technology for vocation, for their life. There are many different softwares which are available, accessible games, text to speech, whatever is there on your screen will be read out. All these increases the exposure of the child, increases the conversation building for the child. You can also look at, there are screen magnifiers, there are narrative. These are all accessibility features in your Windows thing which is available. Use that as a parent, as a special educator, to give more options. The features of the PDF format, we all know the PDF, we download PDF. There is a read aloud provision there. Just put it on so the child can listen to it. There will be storybooks, that could be news, that could be anything. But just listening will give them the increased exposure to many things happening around. The magnifier, the zoom, the revert colors in the iPads, iPhones, as I told, the read please programs, these are all very important for the students who are moving towards becoming independent communicators, because independence in communication and having a vocation, having being independent in their other skills are all together. You can't separate them. This is for communication, this is for vocation. When you have a laptop, when you have a system, put all of them together, because it's the same. Now for communication partners, here the big one is the unfamiliar people. They should be able to communicate with the unfamiliar people. Now, what happens with the communication? Communication happens all the time and with all people. So you are preparing your person to be able to communicate. Yes, there are people who might have complex communication need, who might need an interpreter, who might need a different sort of a support, but still the independence in communicating what they want is what we need to look at. Communication system should be always made available, whether it's a low-tech chart or a high-tech solution, doesn't matter. Now, as successful, to make ASC successful, you need to have creating opportunities. Every minute counts for communication. It is not that I communicate in the morning. It's not like taking a tablet morning, afternoon, evening. Communication happens through the day. As a parent, as a special educator, as a teacher, as a friend, as a stranger communicating with a person, we have to be as a communication partner. Whether the opportunity is there for the person to communicate has to be taken into consideration. Now the support in moving them to become independent communication has to be worked on. The support, I said, maybe a interpreter, maybe a voice output device, whatever it is, has to be put in place. AAC should be available for the person all the time, and include the AAC user in all conversations, because their opinion matters. With this, this is the stop sharing. I'm ready. I'm open for any questions. I hope it was audible and clear.
Yes, ma'am. Yes, ma'am. It was very informative, and your presentation really had lots and lots of ideas and thoughts that the participants to carry over with the education and implement directly with the children who have the need to communicate at ease. Thank you so much, ma'am. Now we'll move on to the question and answer session. Since we have the YouTube link that has been shared with the participants, I have got a set of questions for all the presenters, which I'll be putting forward now for the participants to listen through and help them with the clarification that they had to get to know. Yes, ma'am. So now I request the experts, the speakers, to join in this QA session. Yeah. Now I'd like to invite Shri Kamraj sir, the HOD of Department of Special Education. Sir, there is lots of positive feedbacks on your session, and there are few questions, like many questions, which out of which I've chosen questions for answering now, which should help them in understanding. We have Bijaya Kumar Sahu, who had asked a question: how to draw attention of a cerebral palsy student in a regular classroom setting? Sir, I say the question again. How to draw a palsy student in a regular classroom setting? Sir, Kamraj sir, can you please help the participant to clarify?
Yeah, that's a very good, that observation. The attention, drawing attention of the entire classroom is the duty of the teacher. So the teacher has to plan in such a way that no child is ignored. No child is ignored in the classroom. So that is,
Excuse me, sir. Can
yeah.
you reset your camera, sir? Your face is not visible. A little you take it for. Yes, now it's okay. Thank you.
So it is the duty of the teacher to draw attention of the entire classroom, including children with cerebral palsy. So children with cerebral palsy, they get bored, or they get sometimes they don't attend to certain activities because it is, they feel that it is not addressed to them, or they are not attended to. So the teacher has to make certain availability, certain arrangements, so that the children with cerebral palsy also addressed, and then the attention is focused towards the content which is taught in the classroom. So the content has to be made easy or made accessible for the children with cerebral palsy to participate, so that they enjoy and then participate in the classroom. So if it is not available for the children with cerebral palsy, definitely they will get bored and they will feel that they are ignored. So as I told you that that make the arrangements in such a way that the content adaptation or the environmental structure or the material which is accessible in nature. So these factors which enables the children to attend to the activities. The children with inattentiveness. So definitely if you address the children with that verbatism or lecture method, or without any the material which is not accepted by the learner, so definitely they will not cooperate. And you have to make sure that the classroom is enriched, the classroom is participatory, or very much it is including the children with cerebral palsy by making certain arrangements. So the classroom can be phased out, like that don't keep the classroom for a long time, so that the children with certain issues, they will find it very bored, or they will not attend to the classrooms, no activities. So you have to phase out in such a manner that all the children are engaged, including children with cerebral palsy. Like that you change the activities, keep on changing the activities with the same teaching the same content. So in a phase out manner, if you plan, definitely you can engage or make them participation, and not only changing the activities, but all the activities should be in an accessible or participatory manner. If you give the timeout, or if you use that timeout program for certain children, and you are using, and your classroom is not enriched, classroom is boring, definitely the timeout will not helpful. So you make a timeout program and make sure that the classroom is enriched and he is feeling that he is missing out the activity, so that he will not repeat or he will not tend to make such a issues. Is that right? Am I answer to that participant?
Yes, yes, sir. Hope they would have got a clarification of what they wanted. Sir, we have another question from Management Naik. His question is, severe CP child of 10-year-old, what kind of intervention suggestions that you would suggest for the parents? I repeat again, sir. It's about severe cerebral palsy child of 10-year-old. What kind of intervention would you suggest to the parents?
The severe children with cell palsy. So I was not clear about the cognitive function is intact or the cognitive function also is impaired. So if the cognitive function is impaired, definitely, so we need to attend to the quality of the life of the child. So we have to provide the n number of supportive therapies, n number of supportive services, so that the quality of the child is improves. We can make the child to live for, or make the child to be with the family and the community for some more years. But whereas if the cognitive function is intact, so we can give some arrangements, we can keep some arrangements to participate in the academic activities, and we can plan certain activities where the children can take or communicate with others to take help to get their activities done. So the question is, that not clear that that a 10-year-old male child or female child or cognitive intact or not cognitive impairment. So that question should be very specific, so that the specific plan can be made to give a quality life to the child.
Yes, sir. Thank you, sir. Thank you so much for that information. Yeah. So now we'll move on to the next presenters session, sir. Like, can we have Rashma Rajan, sir, to join in answering the queries put forward by the participant? Yes, sir. Yeah. We have a participant of Rajalakshmi. Her question is, tell the key points that have to be kept in mind for early intervention of children with cerebral palsy. And she has added on, the way, can you please explain the ways to identify the child as CP during prenatal period? Rajkumar sir, did I read out well? Should I say it again?
Just the second part of the question.
Yeah, the second part is ways to identify the child as cerebral palsy during prenatal period.
Okay. Thanks for the question. So the key things to keep in mind when we do early identification or early intervention, as I said in my presentation, we need to think about the family as well as the baby in front of us. It's not just about the baby, it's also about the support that we need to give to the mother or and the father of the baby. So because their mental state will be completely different, because they had an expectation and then now they have a child completely with high risk or with brain damage or already diagnosed to have some specific issue. So if the parents are not in a good state of mind, and then they will not be able to provide a very rich environment for the baby to cope. Okay. And also think about the baby. So just like we think about the family, we need to think about the baby's before thinking about the physical aspects, we need to think about the baby. The newborn baby is in the process of adaptation. What does that mean is, before birth, the baby is in the mother's womb where the environment is very closed. The baby would have experienced certain routine. What I mean is, the baby may have experienced certain routine of the mother. The mother may sleep at a particular time, wake up at a particular time, so eat at a time. So the baby is used to all those kind of routine. And in the womb, the baby has a very rich environment. It's a closed environment. It's not as bright as outside. The sound, it's not so noisy as outside. The baby is used to mother's heart rate and the digestive sound and all those things. So there, the baby was in a very protective environment. And then if you see, the posture of the baby will be very flexed. And because in the last trimester, the baby grows in bigger size and there is not much room. So the baby start to flex. And that's why newborn babies they appear in a flexed posture. So from this environment, now the baby comes out to the world, and the environment here is all of a sudden is open. And it's very noisy, it's too bright, and any little movement, the movement will feel heavy because suddenly the baby experiences too much gravity. Okay, so now the baby is in a process of adapting from the environment of womb to outside environment. Okay, so on top of this, if the baby has got any kind of problem in the brain, it is too much, it is overwhelming for the child. Okay, now if the baby is born at term, is different. If the baby is born preterm, then there is a problem of moving from one stage, moving from the behavioral stage. There are 6 behavioral states, like the deep sleep, crying. So crying is one end and deep sleep is one end. So the baby will be able to move smoothly from one behavioral state to another behavioral state if the baby is born at term without any problem. But if the baby is high risk, and if the baby is born, say for example around 24 weeks, then this baby will have difficulty to sleep, will have difficulty to cope with this environment. The baby will be irritable baby, it will be crying all the time. So this baby will not be able to self-soothe. So there's so many other issues. So this is what we have to keep in mind. So we are not just going to talk about posture or movement to the parent, but we need to allow the baby to adapt. We need to create an environment so the baby can adapt. At the same time, we are going to support the family so the family is also able or ready or able to cope with the current situation and ready to help the baby. Okay, so hope this answers the first question. The second question, things that to keep in, the things that how we can identify a child who will develop cerebral palsy in a prenatal period. So in the prenatal period, one of the high risk during pregnancy is one of the high risk for CP is preterm. These days, compared to before, we have more preterm babies. Those days, in like 30-40 years ago, when they are born, they don't live because we didn't have enough medical technology. Now we have so much medical technology. Babies born so early, they are still alive because of the advancement in treatment. With that also comes the risk of being high risk for developing cerebral palsy. Not all the babies who have who are preterm, they develop cerebral palsy. But also at the same time, children these days who have cerebral palsy, most of them are preterm. So you have to keep this in mind. So preterm is one high risk. And also the other things is the health of the mother and the habits of the mother. For example, smoking, drinking, all those things are a high risk for the babies to have some brain damage. And also the mother having diabetes or hypertension, or they're developing some sort of infection, and then how that infection is being treated, all those things also can pose risk. This is from the parents' perspective. from a medical perspective, during the just before the birth, delivery of birth, the timing of delivery, the accessible to the hospital as soon as possible if there is any signs of water breakage and all those things, accessing the hospital really as quickly as possible is very, very important. In the hospitals these days, there are so many negligence issues. The hospital staff should be able to identify as quickly as possible the issue the mother is having, and then based on that, starting the treatment as early as possible. Sometimes people will start with one very common thing I will say here is in UK, when they would go to normal delivery. In the normal delivery, then it will depending on how much dilatation has happened, depending on the mother's ability to push the child, and depending on the child's ability to participate in the birth process. So all these three things plays an important role. If there is any problem in one of these things, then the labor is going to prolong. The longer the labor goes, then the consultant may decide at one point, try forceps delivery. But if it is not successful, then they will go for cesarean. Okay, so now by the time they decide to go to emergency cesarean, already there is so much time spent in this labor. Okay, so that poses a lot of risk for the baby to suffocate from from getting enough oxygen. So in this process, not getting enough oxygen plays a very important role in damaging the brain. The brain structures are very, very sensitive at this point in time. Any deprivation of oxygen will easily cause to certain structures in the brain, and because of that, they may develop different types of cerebral palsy. Okay, so the labor is very, very important. If they think the parents are have some complications, it's better to plan cesarean right from the beginning rather than going to normal delivery and then going into emergency cesarean. This is one of the very common causes here. And yeah, so in terms of preterm, these are the main things that we can look to identify CP.
Yes, sir. One more question from Rabindra Gochat. His question is, what are the reflexes to identify the child as having cerebral palsy on labor table?
Okay, so based on the reflexes, it's very difficult to say the child will have cerebral palsy or not. So the reason we do newborn screening and check reflexes is to check whether the ability of the child to respond to a stimulus is there. Some babies who are very, very normal, they do not have any problem. But if they are very drowsy, they are in a very sleepy state, and then you go and check the reflexes, of course, the response is not going to be very good, isn't it? So then you cannot make a judgment. Okay, so it is just to see whether the nervous system is intact. And again, just by screening once, you will not be able to understand. You will have to correlate with other clinical presentation to see whether there is any risk of having any brain damage. Okay, but we cannot pinpoint to one particular reflex to say that if this reflex is present, then the child will have cerebral palsy. Okay, we cannot say like that.
Yes, sir. So one more question to you. There are many questions, but because of the time, I'm just restricting to few questions, sir. Another question is about from Mithali Sharma. Her question is, she wants to hear about the practical applications about Bobath techniques in current scenario.
Can you say that question again, Anastasia?
Yeah. The Mithali Sharma, her question is, she would like to hear on Bobath techniques practical application in current scenario. How is Bobath techniques being practically applied on a current scenario? How is it being taken up? Yeah.
Okay. So in my presentation, whatever I spoke is based on the principles of Burpat. So your question is so general. It's difficult to cover, isn't it? So, but the presentation that I did about the principles that we need to consider when we design a home program is based on the Burpat concept. The key principles in Burpat concept is training the parents, transdisciplinary approach, and you know the treatment is very functional. Is so these are the main things, and the fourth one is, I also said in my presentation, we want to focus on quality, not just the independence. So when we try to just push for independence, we compromise quality, and then the child will have problems in the future. It may look successful at the moment, but when we look forward, when you look to the future, in the future that particular child may experience so many problems. So in Burbath, we try to see now and also for the treat now, for the now and also for the future. Okay, and the treatment involves parents very actively, which you all do. But keep the principles. In my presentation, I gave some principles how to involve parents and what to teach to the parents. So, and then if you follow that, I think that way it's very successful. Yeah, that's all I can say about. If the person can ask even something very specific, it'll be easy for me to answer.
Yes, sir. Yes, sir. Yes, sir. Thank you for such a patience answering, sir. Like there are many questions, but now I'm moving on to the next presenter, Srimati Kalpana Rao ma'am, for her sessions. And there were many positive comments apart from the queries. And I will start with a question asked by Prasanna Kumar Patnaik. His question is there any specific keyboard developed for children with cerebral palsy? Is there any specific keyboard developed for children with cerebral palsy?
I think I understand it is about, he's asking about something in India which has been developed. That I don't think so, but there are lots of adapted keyboards available online. All you have to do is just go to the Google and say adapted keyboards, and you can get the whole list. You can either write to me, I can even send you the link later.
Yes, ma'am. Like another question from Annapurna Pishupati. Her question is, what is the difference between aided and unaided categories in AAC?
See, the answer is aided is getting support from something. Unaided is being independently doing. Okay, when you're doing a gesture, it is an unaided. That can come. If it is a low-tech chart, it's an unaided thing. But if you're looking at an aided communication, you are getting support from using a pictures, you are having, there are a whole lot of things. The basic difference would be aided is taking support of something else other than your body. Unaided is using your own body to communicate. This is the broad classification. But when you are coming to low-tech and high-tech communication systems, it gets mixed up into both of the things. Basic method is aided is you're taking a support from something else to communicate. Unaided is you are using your own body like a speech or vocalization or a signing.
Yes, ma'am. Another question about your session. It's from Piyush Goswami. His question is, how can we make a communication board?
Communication board, because I just went through that there will be different levels of communication for the children, and they might be using a communication board using a picture or a word or an object or a tangible system. So what I think he is I am assuming, are you asking about the vocabulary selection? Because a communication system or a chart will have the words to be used. The word could be picture or it is a tangible thing, but it is a vocabulary which can be used. So choose, as I said, there is a core vocabulary and there is a fringe vocabulary. Start with the vocabulary which you want your child to start using. And those vocabulary can be made and put it into the communication chart. Nowadays, you are able to get a lot of free downloadable pictures are available online. You can try downloading those pictures if your child is at a picture level. If your child is only at an object level, you can use even the objects as an object of reference and start using that. If your child is already able to identify words, you can write and spell as a sight word, you can create the word. Main thing, a communication chart will have the vocabulary you want the child to use. So that can depend upon the context in which you want to start communicating. Say you want to take him to a temple. Whatever the vocabulary you will be using in the temple can be put into that communication chart. Other than that, they can also have a general communication chart, which will have questions, which will have all the functions functions of communication which I went through, like greeting, saying thank you, commenting. All those are functions. Those are the things which we use to converse with each other. Those can be also put into the communication chart. But we need to decide at what level the child is and use those vocabulary and the spacing and the sort of a method we are using depending on the child's ability to communicate.
Ma'am, another question. Can you please highlight on the mechanism on Aditi?
Yeah. Aditi is a movement sensor switch. See, what happens is when you are clicking on your mouse, it is a left click. You use your hand to click on the left click, and that is how you highlight something and click. If you are using any other switches, like the switch I showed you, a Big Mac, that's a red color round, what they have done is increase the space of the left click. So it becomes, when you touch and tap on it, becomes a left click of the mouse. But there are students who are unable to do the tapping. So they might be having involuntary movement, which we would have identified and said, okay, the child is able to lift the hand or move the head. So how do I tap that into a system where I can use that for using it on a laptop or a system or as a left click? So Aditi is a movement sensor. If you have Aditi, if you're placing it at near the head and the child is able to move, yeah, they're not touching Aditi, they're just moving. That movement is captured by Aditi as a movement and it becomes a left click. Okay, so Aditi is actually connected to a computer which has a software running. Say it could be a scan mode, which is an on-screen keyboard, or a picture system. Aditi, it will become a left click because it will catch the movement of your any part of the body. It could be with the foot, it could be with the hand, it could be with the head, any part. You don't have to touch. You move 6 inches away from that screen, it comes as a movement it catches. I hope I am clear on that.
Yes, ma'am. Thank you. Thank you so much, ma'am. Ma'am, I'll just come back 2 questions to Rajkumar sir session, like one query that came just about. Sir, can I put forward this now?
Yes, please.
Yeah. And they want, this is Annapurna Pishupati. Her question is, what are the strategies to treat a child with CP who have oral sensory disturbances?
Okay, thank you. So sensory disturbances can be anything. So we have different sensory systems. We have tactile, touch. We have proprioception. Proprioception is the movement sense. Like when you move a part of a body, information from the joints and the muscles that move that part of the body goes to the brain, telling the brain that that part is moving. That's how we understand the movement from our body and our position in space. And then we have our vision. Vision tells us about, it gives us information about the environment and also about our position in space. And then we have something called vestibular, which is inside our ear. It's nothing but like a fluid. When our head moves and the fluid is also moves, that way it detects movement. And that also gives us information about our head, our position in space. And then we have, of course, smell, we have taste, and then we have hearing. So all this sense senses can have problems. The main issues most of the time will be their sensitivity. They may be hypersensitive or hyposensitive. So when there is a stimulus, for some children, that stimulus is not enough. So like when there is a ceiling fan, you turn the fan to 1, some people will say, oh, it's very cold. So they are sensitive. For some people, if you turn to 5, only then they will feel that they can feel the air. So like that, the threshold could be low or threshold could be high. So based on the sum of the sensory system, they may have dysfunction. They are say, I'll give a few examples. So when a mother is trying to feed a child, okay, and if the child just by seeing the food may start to gag, okay, so that means the child may be there could be different reasons. The child might have had bad experience in the past, because of that the child may gag, or the child may be hypersensitive in the oral structures, and because of that the child may gag. Okay, so the opposite could be, you may see a child after eating, there is food particles around the mouth, okay, or the child may be keeping the mouth open, and then the child may be drooling a lot, okay. So food around the mouth, the child is not able to particles around the mouth, because the child is hyposensitive, okay. This is the opposite. And in terms of drooling, there may be a motor issue as well as sensory issue. The child may not feel the liquid secretion, and then it's the pooling of saliva in the mouth, and so the swallowing is not automatically triggered. On top of this, they may have a poor head control or open mouth posture, and because of that, the liquid is coming outside. So you may have issues like this. So the general principles is to make sure we don't trigger any aversive responses to these children. If you know the child is going to gag and the child is going to become sick after one certain type of food, then it's better not to present that particular food. Okay, so then this is not purely boba, but this is more like a sensory integration approach. Then there are strategies where we can use either to desensitize the child before a particular food is being offered. Okay, so the desensitization should not happen just before the child is being fed. It should be in other time. Okay, during feeding, it's better to focus on feeding rather than trying different treatment strategies, isn't it? So we don't want to do things like that. Another example I can give you is if a child is fearful of movement. When you try to pick a child and the child panics because the movement in space freaks the child out. So in that child, then what we have to be is we have to just give enough support to the child. When we say enough support, found that deep pressure seems to help. So the deep pressure seems to help the child to know where they are in space. That's one thing. Then move the child very slowly. Okay, so one of the reasons they are fearful of movement is the vestibular is very sensitive. So now for the vestibular to adapt to movement, we can try different things. We can use an apparatus like a swing. We can use a swing to treat the child. And when we use a swing, the principles mainly are like linear movement. Linear movement is forward and backward and side to side movement. And if it is slow and rhythmic, it will help the vestibular apparatus to adjust to movement. But when there is any rotatory movement, which is very stimulatory, the child will freak out. Okay, so we have to use the right movement in the right apparatus. So without apparatus, how can we treat the fear of movement? Is to give movement experience. So floor level, where the child can adjust to being moved or move actively. Active movement is better than passively being moved. So actively the child moves on the floor and slowly off the floor and then in the space. So that way, the child will be able to adjust to movement and will become less fearful. Okay. So again, the question is very broad. It's difficult to answer that question. So I just took a couple of examples to explain.
Yes, sir. Yes, sir. Thank you, sir. Thank you all. Like now I would move on to vote of thanks. We are coming to the end of the webinar. I take this opportunity to thank our officiating director, Sri Nachiketa Rao, for permitting me to organize the webinar. And I also take this opportunity to thank Sri P. Kamaraj, our HOD, as a Department of Special Education, for his encouragement. I would like to say my humble gratitude feel to all who have directly and indirectly supported in conduct of this webinar. Thank you. Right side. Okay. Okay. Thanks.
Again, we want to put that link.
Feedback, amma. நான் முதல் போட்டுடுமா கடைசியா அதுக்குள்ள போட்டோ போட்டுட்டீங்க feedback போட்டுடுங்க நீங்க பார்க்கல அவங்கதான் சின்சியரா கொஸ்டின் எடுத்தாங்களே அப்படியா